everybody? Perfect. Thank you very much. I'd like to just welcome you all to this webinar. It's a very exciting topic. It's a very exciting speaker. I'd just like to give you, if I may, a small bit of information about us. This JDJ Diagnostics is a molecular pathology lab or a pathology lab, and we're based in Durban in South Africa. We have laboratories in Tyger Valley, Worcester, Caledon, Polokwane, Pretoria, Mthatha, Pietermaritzburg, and Port Shepstone. So we are growing. We are moving our way up. We also want to offer genomic testing, and the first test we're looking at offering is the pharmacogenomics, which we believe will help patients to get the right drug at the right dose to achieve their treatment targets and reduce adverse reactions. We are really proud to be partnering with Corielll Life Sciences, who will be supplying the analytical power behind our pharmacogenomics analysis. And this is why it's even more relevant that we have Jeff Shaman chatting to us tonight, who's talking about the approach that they use and the power that's actually behind this analysis that they're offering. Before we begin, I'd just like to let you know the policy, the implemented policy here is that everyone, all participants will have their cameras and their microphones muted. If you wish to comment or chat, please put it in the chat box. There will be questions and answers afterwards. So if there's anything, please just keep it ready. As you may have seen, this session is being recorded. So just to notify that you are being recorded, and it will also be published on YouTube after the event. We will distribute the link and make the link available on our website so that everyone can go back and review it and watch the good bits again if they want to. So I would like to just start by thanking Jeff so much for joining us. Jeff is the Chief Science Officer at Corielll Life Sciences. He's an international leader in precision medicine. He's worked in genetics and pharmacology, and he's an expert in pharmacogenomics. He really is an expert. So when you're looking for one, he's the guy. He plays a critical role in bridging the gap between science and clinical application. And this includes translating the decades of cutting-edge research into actionable insights. We are looking at the most effective medications for individuals based on their DNA and other factors. This is really where I think we're talking about the power of the system that's coming from Corielll. Jeff has a PhD in, sorry, turn page quickly, from Johns Hopkins University School of Medicine in pharmacology and molecular sciences. And he is highly respected in the field, and he will hopefully be showing us what it is that Corielll is going to do for us to really give us the most amazing and useful implementation of pharmacogenomics that we can get. Thank you, Jeff, and welcome.
Yeah, thank you, George. It's good to be here with everybody this evening. I'm really going to go through pharmacogenomics through the lens of a pharmacist, from the patient's point of view, from the healthcare system's point of view as well, with an eye of understanding what pharmacogenomics is, what pharmacogenomics can do for these folks, and then provide some scientific articles to show you the outcomes of some of these genetically empowered medication management programs that we've been running. To start off, a little bit of history, since I don't think we all know each other, but next time maybe I can visit and be with you in person. Then there's a benefit to that. But please ask all the questions that you have. I'm happy to answer them, and we've got quite a bit of time here this morning, and I'm not going to talk through all of it because I'd love to hear from you what your questions are. Corielll Life Sciences was born out of the Corielll Institute for Medical Research about 10 years ago. The Institute has been around since 1953. And the Corielll Institute launched a study called the Corielll Personalized Medicine Collaborative in about 2007. And the goal of that study was to understand the best practices of providing genetic information to mostly physicians, but also patients. And that was around Mendelian conditions, but also pharmacogenomics. To get this out to patients where it's going to benefit folks the most, we took our company public, or not public, but out of the nonprofit organization 10 years ago. And we're now located, our headquarters in Philadelphia in the state of Pennsylvania on the East Coast of the US. So I'm going to get past a lot of this introduction stuff, but we're going to talk a lot about both the science of pharmacogenomics, what data analytics has to do with this, how using a clinical decision support software can actually improve how we introduce these information to our patients. So the problem that we're talking about today is that medications don't work for everybody, right? Whether you're a patient on this call or a physician on this call or a surgeon or an anesthesiologist or a nurse, pharmacist, we all know somebody in our lives who's taken a medication and it hasn't worked for them, or they've taken a medication and they've had a side effect. And the reason that we're talking about this today is that we can use genetic testing to do something about this. We can do preemptive testing and have a good understanding of the medications that are going to work for a patient and those that aren't, and those that are going to have side effects and those that aren't. And we're definitely going to talk about some large implementation studies. And again, that published positive economic and clinical outcomes data. And as long as we've got some time, I want to dip into the humanistic portion of this as well, because I'm constantly reminded and like to talk about the fact that this isn't just numbers from a public health standpoint. It's not just a financial issue, but it is a quality of life issue amongst our patients, but also the physicians treating them. Now, these are some numbers from the United States, but what I've seen by giving talks in Africa and South America and Asia and Europe is that this is seen everywhere. And that is the fact that a lot of prescription drugs are utilized in the world, and they're there for a good reason. But there are outcomes that we don't expect and don't desire, right? We look at those drug labels and it says, take 2 of these and call me in the morning. But not everybody is that person, right? And so some people we need to give 4, some people need to give 1, and some people we shouldn't be giving this at all to. In the US, 1 in 4 Americans uses 3 or more prescription drugs. That number is only increasing. And I work a lot with our geriatric population where that number averages anywhere from 11 to 13 and gets around 24. And those folks aren't outliers. And so when I talk about this, we need to consider the pill burden that our patients are taking, whether they're young or old. We also know that the FDA and others have published that 50% of patients are on drugs that fail to be effective or that cause side effects. These drug reactions result in emergency room visits, hospitalizations, and they can also be fatal. Let's do what we can to avoid that. We're going to talk about a bunch of different specialties and where pharmacogenomics can be utilized. And what I want everybody to know is that anybody who's on an antidepressant or cardiac medication isn't only dealing with those things. It's the same conversation I have with our oncologists. Nobody is just dealing with an oncologic issue with that neoplasm. They are also dealing with depression and pain and nausea and vomiting issues. And the medications that can be utilized in those are the ones that we're going to be talking about today. We all know that treating depression, anxiety has all been challenging. And here are some of the reasons, right? 50% of those patients with depression do not respond to their first treatment. 30% of patients discontinue treatment due to intolerable side effects, whether it's simple as weight gain or sexual side effects. And a patient not taking those medications, right? That non-adherence, that's as good as not being prescribed it, right? Whether it's good or bad, they're just not getting any benefit out of those medications because they're not taking it. And again, we're having this talk because we can avoid these issues. Now, I think most of the folks with us today have a good understanding of what pharmacogenomics is, but let's just remind ourselves, pharmacology, the science of how drugs work on the body. In genomics, we're going to talk about how genes work on the body. Now, as you can imagine, I can wax poetic about genetics and pharmacology, but let's at least get a basics of a good vocabulary together. Okay. The way we think about this is a genetic variant. There's a change in the molecular activity of either a pharmacokinetic or pharmacodynamic gene, right? These medication or genes that are associated with absorption, distribution, metabolism, and excretion. And that includes both those metabolics, but also transport of medications across cell membranes. Okay, so we're going to talk a little bit about both. We can lump them all together because the outcome is the same. But those variable responses due to this has an effect on the patient. And when we have genetics more like what we expect from those drug labels, we would expect that that take 2 of these and call me in the morning is absolutely going to work. But sometimes we have duplications in our genome, right? And CYP2D6, it's a cytochrome P450 gene. It's in the 2D family, and it's number 6, right? It's we're very creative when we come up with the naming scheme of these metabolic enzymes. Suffice it to say, we know that that gene can be duplicated in our patients, and that's not always very rare. In that case, having multiple copies of the genes means that there's a change in molecular activity. There's more of that enzyme around to do what it's supposed to do, whether it's to increase excretion or if there's a prodrug to create that medication. And those ultra rapid metabolizers, of course, have an outcome effect. We can have the opposite effect as well. We can have deletions. We can have changes in the genetics, right? So different variations of the genetics impact the effect on the patient so much that we have what we call intermediate metabolizers and poor metabolizers. Poor metabolizers of drugs for CYP2D6 are not able to metabolize those medications at all. And those can be point mutations, longer mutations, variable length mutations, or complete deletions of one or both alleles for the patient. What we want is a drug to be non-toxic and beneficial. But if I gave the same medication to 2 different patients, same diagnosis, same prescription, I can get different outcomes. And this is what we want to learn about here. Those therapeutic areas that we're going to talk about, maybe not at length today, but we should consider about as we're asking questions towards the end of the conversation here. These are the specialties where this is helpful. Oncology, of course, has the most right now. These are companion diagnostics, right? Medications that we know impact like non-small cell lung carcinomas and KRAS and VEGF and these mutations that if they exist, we don't want to give certain medications because there are medications directed towards those genes, right? The Herceptins of the world. But the ones that we're going to talk about today are these other ones. Neurology and psychiatric medications really shine here. And we can talk more about those as well because it takes so long for these medications to work in the body, right? We all remember that it takes sometimes 6, 8, 12 weeks to see the benefits as these medications are building up and there's in the synapses. There's new papers on how that happens and why that works that even just came out this last month that are absolutely worth reading. But the idea is, why give a person a medication if in 6 to 8 weeks it's not going to work, right? Let's use that time for those medications to build up in the body, find the right drug, and this is now avoiding trial and error prescribing, or as my marketing buddies like to call trial and failure prescribing. We also know that cardiology, infectious diseases, anesthesiology, things like malignant hypothermia, all based on genetics. We used to just ask for, were your parents of such and such descent, right? But we don't always have that information. So having the genetics information is also helpful. Our hospitalists love this information. If a patient is also adopted, this information is absolutely helpful to get people on the right medications. As far as biomarkers, we can dive deeper into these, but these pathways here are ones that have been described over the course of the last 20 years in depth. In fact, we've actually known about G6PD probably since Roman times and Greek times. Pythagoras, you might remember the story of Pythagoras running away from a bunch of soldiers and running into a field of fava beans and not wanting to continue. Well, it turns out that favaism is caused by G6PD, which is a pathway that a lot of the oncology medications go through as well. So Pythagoras actually knew about pharmacogenomics, even though the term wasn't coined until several decades ago. One of the medications that we should consider as a good model of understanding pharmacogenomics is Plavix or clopidogrel. Now, clopidogrel is a little different than these medications that I was talking about that are excreted. Clopidogrel is a prodrug, which means that when you take it, it's not active in its own sense, but the body turns it on, it activates it. And that gene that does that is CYP2C19. And you can imagine if 2C19 wasn't working, right? This patient is a poor metabolizer. That means that clopidogrel cannot be turned on. We're now not talking about a side effect of a headache or a bellyache. We're talking about a secondary cardiovascular or cerebrovascular event, right? This is as good as eating candy to try and cure an issue. And we give this medication to keep stents open, right? We give this medication to make sure that our patients are not at risk of a major cardiovascular event or bleeding. And there are other medications out there that do not use that same CYP2C19 pathway. And you can see that once you get folks on those right medications, those risks of MACE and bleeding are decreased. The same is true for those dealing with major depressive disorder and they're on antidepressive therapy. Those folks who use pharmacogenomics for those patients see outcomes a lot faster than those who are using the trial and error prescribing. And I can share the paper that this came from with everybody after the talk, if helpful. Maybe I'll provide that to you, George, so you can disseminate that for those folks who are interested. But this isn't the future. This is now. We've known about some of these issues like DPYD and capecitabine and fluorouracil since the 90s. All right. So we know the clinical utility. We know the lab technologies like George's lab. The technologies that they're using can pinpoint very specifically what needs to be detected and evaluated in the genome in targeted studies to be able to provide these clinical decision support tools. We also have a good understanding of how to bring this about, and it's working together with you, pharmacists, physicians, surgeons, hospitalists, public health folks in hospital systems as well. Everybody in this audience has a place in making sure that pharmacogenomics is utilized well to do good. User acceptance throughout the world has increased. So that was always a barrier to entry for pharmacogenomics, and that user could be either the patient or the healthcare provider. And we've seen that all across the board increase over time. And that last barrier to entry was the economic value. And we published a paper last March, 2 Marches ago now, 2022, and the largest study of its kind showing the economic value of pharmacogenomics in a population. And since then, we and others have published on studies that really replicate the same results in both different populations, different sizes, and different places around the world. So as time has gone on, we've really reached a tipping point that pharmacogenomics is ready for large-scale usage in our populations. And all right, so it's helpful. I think I mentioned this as I was introducing the first slide. It's not just the patients that see the better outcomes. There's improved quality of care. This really is personalized medicine at its best. We want to address the patient's goals as healthcare providers. And some of that should be to improve safety and efficacy, right? Understanding if that patient is bedridden because of a pharmacogenomic issue with their statin is helpful, right? They might say, "Hey, I don't need to live forever. I just need to be able to get out of bed and play with my grandkids and walk the dog." We know that improved quality of life is very important. There's also lower cost, and we'll talk about that when we dive into the studies a little bit more. But this is both for the patient and the healthcare system. And around the world, the way that we reimburse for insurance and that patients pay for their own healthcare is a little bit different. But what we have seen is that that cost goes down for anybody who is responsible for paying for healthcare. And that's not always just the pharmacy spend. Oftentimes it is a little bit because we're getting rid of medications that are being utilized to deal with side effects. And these medications we put on board to make sure that those side effects, those issues are reduced. But what we see is that sometimes the medications we put our patients on are a little bit more expensive. That Plavix example is a prime one, and that the other two options of ticagrelor into prasugrel, those are a little bit more expensive. But what we're avoiding is that secondary event downstream, those hospitalizations, those surgeries that are necessary, and thus the lower cost. We're also, though, helping the care team, right? The healthcare providers that are doing this by increasing scalability, increasing efficiency, providing information that allows folks who are really naive to some of these genetics to still understand how it can be utilized in the clinics. My goal is that I'll let me and my team dive into the geeky, nerdy aspects of molecular diagnostics. But if I can't make it very clear and easy to understand and clinically actionable, then I haven't done my job. And so when I work with George, we're always back and forth about making sure that we understand the feedback from our healthcare providers such that this information can be used at the point of care rapidly. None of us have time to read through gigantic reports. We want to dive in, find the medication that my patient is on or the medication my patient is about to take, make sure that it's very clear what can be done and that it aligns with the research that's available in the world today, and present that. And that's what Corielll Life Sciences has done. I've got a team of curation research scientists and clinicians, and we take the best of available information, both from drug labels, from universal guidelines, and the peer-reviewed articles, and we curate those in a way and come up with a summary understanding of what it means for an individual drug to be impacted by a certain variant in a gene and what that outcome is. And only when it makes its way to a certain threshold of evidence is it ready to be put on one of these documents so it can be used in the clinic. There's a lot of information out there, case studies, small research studies that don't have the kind of population, right? The N number that you and I would all like to see. So when we come across those studies and those guidelines and those drug labels that do have the evidence behind it, we want to make sure that it's easy to get that into a clinical space that you guys can utilize it in. The other part about this that I really want to get across is that pharmacogenomics isn't the only thing that we need to consider, right? We need to consider these other concerns and risk factors that we've always been thinking about as healthcare professionals and pharmacists, right? And these include things like drug-drug interactions, anticholinergic burden, age-related risks and toxicities. Here we use the Beers criteria for our patients over 65, contraindications, pregnancy and lactation warnings. All of this needs to be in context with the patient's genetics. And what we have done at Corielll Life Sciences is we have a medication safety program that we call Corigen, But what this is designed to do is provide information to make informed clinical decisions. And that means understanding who we're testing, making sure they have access to this, making sure that the laboratory is getting that data into a clinical decision support tool, like we'll talk about next, which is GeneDose Live, and those improved health savings at the end. Now, it may be that one day we'll all have our genetics in our back pocket, right? It'll be on our phones, it'll be accessible on an app. In the meantime, I think that testing for pharmacogenomics, testing those people first who are going to benefit the most is the right way to go. I'm an absolute proponent of testing everybody eventually. I think everybody will benefit. Look, I'm not on Plavix or clopidogrel right now, but if you find me passed out at a bus stop and you've had to do surgery on me, please do not give me Plavix. I am a poor metabolizer at 2C19. This is an example of how this pharmacogenomics in a proactive way can help. Now, right now, a lot of pharmacogenomics is done reactively, right? We have patients who aren't reacting to their anxiolytics, antidepressants, their cholesterol medications well. I think that that's the right way to start. But we can help folks with a population analytics, look at the whole population and say, hey, these are your top most risky people, and maybe let's address them from a public health standpoint, right? And do that en masse. Right? If you're at a hospital system, this is a fantastic way to look at things. If you're in an insurance group, this is a fantastic way to limit the risk that you have. If you're a clinician, you probably already have a good idea of which patients would benefit the most from pharmacogenomics and medication safety program testing. Get those people involved, whether that's having those kits right there, working with George to make sure that this is very easy for you to implement. Then we send our kits, our testing off to the laboratory, and George and his team expertly look at all of those variants, those SNPs, those single nucleotide polymorphisms in the genome that we know to impact both efficacy and safety. And also copy number, right? I mentioned early on that copy number variants of certain genes are also impactful. And then reporting those results out back to you or to a helpful learned intermediary, if that could be a pharmacist or a technician in your office. And then if you're more looking at this from a public health standpoint, we can actually work with you to understand the realized savings and clinical benefits that have been made over the course of your programs. I'm not going to dive into some of these slides too much, but we also have a clinical decision support tool. And the goal of GeneDose Live, that tool, is to really surface these details for the user as fast as possible. The old way of doing this was to have a really large report with all of the medications that a patient has pharmacogenomic information. So let me say that again. So the old way is to have a giant report with all of the medications that are impacted by genetics in it. And that's super helpful. That can be put into the electronic health records. It can travel with a patient, but it doesn't focus the attention always on what the patient is taking at that very moment. So what we do is we allow these reports, and George and his team and you and your patients to be able to see very specifically on that first page a summarized understanding of what the patient is taking and what those risks are associated with those current medications. The clinical decision support tool also does that. Where this clinical decision support tool thrives is the ability to audition alternative medications for the patient. So if Plavix isn't good for me, or amitriptyline, right, another antidepressant, if amitriptyline isn't good for me, in the United States, I think we have 72 or 74 other antidepressants on the market, both over the counter, supplements that can help. And the GeneDose Live Clinical Decision Support Tool will surface those medications in the same therapeutic class that are that will increase risk and those that will decrease risk. So you have a good understanding. And it does that in context with the other medication the patient is taking. So if I put somebody on sertraline, but that has a drug-drug interaction, you will actually see that issue live and immediately in that clinical decision support tool. We'll talk about these. This is a very generalized slide of how there are improvements in patients who have gone through this, but let's actually look at some of the studies that have been done to date. One of the large studies that we'll talk about today and is a peer-reviewed article that came out in March of 2022 is our program with the Teachers Retirement System of the state of Kentucky. This is a group that has an average age of 74 years old. They have about 36,000 people in their who are members of that program. And we've tested to date, I think the number is much higher than this, but we'll say it's 11,000 folks at this time. And in the study, we were able to evaluate about 5,200 people. What we saw, even before we tested their genetics, 66% of those people were on medications that react poorly with DNA. What that shows you is that pharmacogenomic testing, once done, can have an immediate impact because the medications that we know the genetics for are being utilized. And I got to tell you, of the 66%, since then, a couple of dozen new medications were actually added to the report because the evidence has now increased. That's the other good thing about this pharmacogenetics that I haven't talked about. When we're talking about oncology, genetics changes all the time in these tumors, right? But in pharmacogenomics, this is a very stable areas of the genome. And so you can test once and evaluate multiple times. And that means that you can test a child, you can test an adult, and not have to test them again in 5 months, 5 years, 20 years, but instead you ask the clinical decision support tool to provide an additional summary report so we can see what updates have been made. Using pharmacists at the center of care for these members of the TRS system, 3 out of 5 retirees had a change to their medications recommended. 87% were at high risk of drug-drug interactions. Again, pointing to the fact that it's not just genetic, but we also have to consider those non-genetic concerns as well. For this study, we had our intervention group, and those are the people who voluntarily enrolled, about 5,200 folks, and the control population that was very well matched were folks that did not enroll into the program, but you can see that they were matched very closely on sex, on age, on Charlson comorbidity index. This is a proxy for 5-10-year mortality rates, and so you can see the issues there. Number of medications was a little bit different. It appears that about 1 more pill a month was given, 1 more prescription a month was being offered to those on the intervention. What we see over time was really exciting to us. If we look at the graph here on the left, those folks in the 12 months preceding the program, and that's if we're looking at the difference between the participants and non-participants, there really isn't a pattern here of savings, right? And that's what we would expect. Before the program, there was no pattern of savings. Once the pattern starts, though, what we see is the difference. This is the amount of savings of participants over the non-participants. And over the course of the 32 months that we studied them, we saw a per member per month cost avoidance that was charged to their insurance plan of about $218. That's per person. So if you multiply that out over the course of the 2288 folks over the 32 months, that's 37 million US dollars in cumulative cost savings for this population. Here's another way to look at this. On the right side here, if we look at our control year over year, and oftentimes I like to draw a line here, but the gray bars are those non-participants. And you can see exactly what we would expect over time. The cost of healthcare increases year over year. What was interesting in our intervention in the participants, they actually cost a little bit more to begin with, right? They were probably a tiny bit sicker. We know that they at least had one extra medication on average between them. But over the course of the program, so this was prior to the program starts, this is the 12 months prior, over the course of the 3 years that we worked with them, you can see the bending of this cost curve downward. Okay, so now we're seeing the economic benefit of pharmacogenomics and a medication safety management program. And we looked very specifically at where these savings were coming from. And it was very clearly in this population a decrease of almost 15% in inpatient hospital stays, close to a 7% decrease in emergency department visits, and a slight decrease in outpatient visits. What happens is, if you look at this data very carefully, over the first year, this number actually increases. It's not a reduction. And that's actually expected because we have asked these members to be active participants in their own healthcare and to take the information that they have from the program and the pharmacists to their physicians to action it. In the United States, pharmacists can't prescribe. In most cases, there are some places where that's where they can prescribe, and those collaborative agreements are often in hospital systems. But otherwise, we need those patients to go out and help. Here are some additional economic studies that we have performed since the TRS study. We've worked with an international hotel chain. As you can imagine, this is a younger population. This was about 500 employees, and they had a return on their investment of over 7x after 18 months. A large manufacturing company had an 8.9x return after 24 months and 1,000 employees. This was a little bit higher than the others. This was enabled by targeting those members who are going to benefit more early on in the program. A large laboratory here, one of the top labs volume-wise in the United States. We've got 3 publications, 2 already published, 1 in review right now. They also saw a very good return on the investment after 13 months. And we're working with the public employees, both active, working well, and retirees of the state of New Hampshire. They've opened this program up to all members, not just a small portion. And you can see that they're having at 11 months just over 6.5x ROI on their program. So what we learned is that it's not an age-related benefit. Anybody who's on medications can benefit from pharmacogenomic testing and the review of those medications. I often don't have time to talk about this slide, but I think we've got a few minutes to, I'll give a little talk about this. One thing that often I hear from patients is, oh, Jeff, I'm just getting older. Yeah, I've got muscle aches and pains. I'm a little depressed. I'm moving slower. It's just because I'm getting older. And my response has always been, yeah, that could be true. But wouldn't it be interesting if it were because of your medications and we can do something about it? Your life would be very different right now. And this is a publication. It's one patient, it's a case study. But what we have seen is this is repeated in testimonials and phone calls and emails that I get from patients on the benefits that they have seen. And what we've done here is shown the patient's medications, what this patient was taking, and the potential side effects from those medications. And it turns out that some of those absolutely overlapped with active aging, what we would expect to see in our population as they get older. It turns out that this patient also had variants in their genome that impacted these very medications. So once we changed her medications based on what we learned from her genetics, we were able to get rid of these side effects. Of course, she was happier, her family was ecstatic, and her healthcare providers also. And so this is one of my favorite parts of what I do. As the Chief Science Officer at Corielll Life Sciences, I get emails all the time from both healthcare providers, but also the patients saying that pharmacogenomics enabled them to get on the right antidepressant. They've been struggling with depression for decades, and they're finally getting it right. Drugs that we consider as simple as omeprazole to deal with things like GERD and other GI issues. It sounds like, oh, just keep trying things. We have patients that have been struggling, missing work, having to purchase special beds, trying all sorts of medications. But once they've taken their pharmacogenomic test, have a good understanding of what direction they should be going in with their medications, they're sleeping at night. Right. And we know that means they're getting out of bed, they're exercising, and that precipitates good health. And that's what we all want to do. So I want to thank you all for taking the time out of your busy days to hang out with me and learn a little bit about pharmacogenomics. And I believe I saw some notes that there were maybe questions in the chat. So I'll let George dive into those and see if there's something that we can talk about. Again, please, if anybody's got any questions after this, put them in the chat, and I'm happy to answer them.
Yes, thank you very much. That, as always, amazing and informative. I did see one question, which I think is really the kind of the crux of this thing. How do we put this into practice? What's the application here?
Yeah, and we've seen this done differently all over the world and all over the United States. And it really is providing the opportunity to take the test. That is the first thing that we need to do. So working with George and his team to make sure that you have, I don't know the job and the professional opinions of the person that asked the question, but if you're a provider, make sure that you're offering this test, whether it's in your clinic, right? Keep those collection, the DNA collection kits in your office. If you're a hospital system working with George and his team, make sure your hospital has a good understanding of who would benefit. Get this out to your cardiologist. Get this out to your inpatient mental health specialists. Your surgical suite. I talked a lot about pharmacists, but we also know that in the surgical suite, the anesthesiologists, at least near us, are the center of care there. And a lot of those patients have to do pre-testing. Maybe it's 10 days before an elective surgery. The medications that we could understand prior to that, the antiemetics, pain management, anesthesiology, the faster we get these patients out of recovery and either home or into a ward means more surgeries being able to be done, right? There's not that backlog. And so there's a benefit there as well. So let's get this, I think, and George, you might have, I don't know, additional information, but making sure that that everybody's getting the ability to take the test and provide these results to the patient.
Yeah, and I think, Jeff, also what we can remember is that we're happy to share the specialist applications. So if we're talking to surgeons, if you're talking to psychiatrists, if they have specific questions and they can put them to us, we can help them with what is the specific application in your speciality. I mean, I think in general medicine, obviously, it's really clear there is, but we also know that people have to become comfortable in their own specialities.
Absolutely.
Um,
So hopefully that answered the question, right? We want to get this out to as many people who are going to benefit the most and being able to test it. And again, those reports, those summary reports are designed to make it easy to implement.
Yeah. Can I read you a question from Nicole? You have listed side effects with intake of vitamins. Are there tests for genes that metabolize these, and what would your recommendations be for people with SNPs or alternatives for some supplementation?
Yeah, so supplements are an interesting beast. We know, and one reason I say that is because what we don't have, at least in the United States, for a lot of these supplements, is standard dosing and standard formularies for what they are. However, we're keeping our eye on them, and as more and more information becomes available, we're adding it. One of those specifically is folate, right? Another is the cannabinoids, right? Which are available sometimes with prescriptions, and sometimes we see our patients taking those recreationally. They both impact the patient, so we need to consider them all. But folate is impacted by the MTHFR pathway, and that is a gene that we've got a really good understanding of, two very specific SNPs, and should be utilized. Some other vitamins, like vitamin A, and our pregnant patients, we've got to be very careful of whether, despite genetics, but we don't have a good understanding yet of impacts of genetics on most of those vitamins. But folate is one, and the cannabinoids is another that you'll see with a lot of research on.
And those, sorry, Jeff, and those are covered in the processing at the moment
That's
through the
correct.
Corielll system. Yeah.
The MTHFR is, the cannabinoids can be added. The research isn't quite yet there for this to be introduced. It's not ready for clinical prime time, but once it is, it will be made available. Absolutely.
So could I ask a question? You just said clinical prime time. How do we set the bar? I mean, you know, just to explain, just to recap for our attendees, how do we set the bar to say level of evidence? You mentioned that term. At what point are we, as the scientists, putting the science behind the clinical decision making? Are we satisfied that we are actually being responsible and passing it on correctly?
Yeah, it's a great question that could be answered by, we have a publication that came out of the Corielll Institute for Medical Research about 13 years ago that describes the metrics that we utilize to make sure that this is consistent. It's a rubric that talks about having in vitro understanding of probe drugs, and in a dish, how important it is. That's a good basic understanding, but that's not enough to get us to that level of this is ready for clinical prime time. What we're looking for is specific research and understanding about a drug and evaluated in a patient where that is usually the only medication, that's very clearly described what variants and what gene are present, and the outcomes are very clearly defined. So it's a drug-gene relationship, and the population, the statistics has to be pretty strong. So there are some that we look at probe drugs, and those probing drugs are helpful in understanding, but the top level, the most evidence that we need are these large studies. The other information that's interesting and helpful are in drug labels, because the drug manufacturers themselves often have some information on their medications and the genetics behind them that aren't always in public peer-reviewed articles. And so we take those into consideration as well. But those information and the information from groups like the Dutch Pharmacogenomic Working Group, the CPIC, and some of these other collaborative groups, those are all volunteer organizations. Our scientists belong to almost all of them and publish with them as well, but they are a little bit slower in getting this information churned out. So the information in those publications are absolutely helpful, but don't automatically get you to that top level of evidence. But it's called PHACES, and that if you just search that on PubMed, PHACES, PHAESIS, you should come across that article to dive into some of the details.
Thank you very much. I have a question here from Bianca Kruger. Thank you for a very interesting talk. You mentioned that only variants with proper evidence from studies with good sample sizes will be added. However, many of the studies done in African populations might not meet the sample size, but could still have an impact. How do you navigate this and ensure that all populations can receive the best evidence from PGX testing?
Yeah, that's been a really important part of what we do here in conversations that I've had with George and others around the world. And that is, if we've got a good understanding of an outcome of a drug gene pair, those outcomes are pretty clear across the board. And that's because, let's use an example. CYP2C19, a paper came out earlier this week describing that folks of African ancestry show a STAR2 variance in 2C19 in 17% of the population, and for STAR17, 22% of the population. Now, what it turns out is that it doesn't matter where you're from, what your ancestry and descendants are, but if you've got those two mutations for Plavix, you need to be tested. What that study was showing is that it is worth testing patients with African ancestry. There is also some recent studies on warfarin that are very specific. But what we know is if your patient, if a person has a variant in a gene that's very well studied, that is going to help you understand what's going on with the patient. Where there is room to grow is that not all of the variants in a certain gene have yet to be evaluated. That doesn't negate the benefits for a patient immediately. What it does suggest is that we're still learning, and that as we understand more of these variants that nobody was adding to their tests originally, that we're adding now, that we're going to benefit. There's another example in 2D6. There's a variant in there that folks said only a Japanese ancestry population has. And I've always said that that doesn't make any sense to me. What it means is that we're probably only testing it in certain people. It turns out that my labs in South America are now showing that their entire population, both their indigenous population and those people who have emigrated or immigrated into their countries, are also seeing that. And now that our labs in our urban hubs here in the United States have added that variant, we're now seeing that it's not a rare variant anymore. And I suspect that we're all going to see that across the board. But what it doesn't do is what it also suggests is it'll benefit people now, but we'll learn more and add to our knowledge base as we go forward.
Yeah. And I think it also, if I may just suggest that implicit in that question is that we need to be reactive. We need to be open to saying, when there is evidence, when the evidence reaches a level that also has to be acceptable scientifically, that we are ready to incorporate that into our analyses and into our processing. Not just to make the bar unattainably high. I mean, the function of a gene, if I can show that you're a poor metabolizer, I can apply all the poor metabolizer logic.
Yes.
Right? I don't have to rediscover all the poor metabolizer logic. I can apply it. But I just need to be, the study does need to get me to the point where saying, if this is a mutation or a variant in an African situation that makes you a poor metabolizer, well, then you're a poor metabolizer.
That's exactly right.
Everything that goes with it. Yeah,
that's right. It's not, it might be in a higher percentage in a certain population, but the variant, it means that there's other changes in the genome that we don't know about. And what I would ask everybody in the audience is, as these become apparent to you and your patients, let George know, let me know. We have to have good conversations between clinician scientists and other scientists that are doing this work to make sure that this grows and improves over time.
Yeah, absolutely. And it's the only way we're going to solve it, not by waiting until everyone in the world has been sequenced and we can actually safely say, yeah. No, I think that's absolutely great.
Yeah, we're not going to get down to that N of 1, right?
No.
We can bucket everybody as much as we want, but we're making good headway in the science here by understanding these genes and drugs.
Yeah, that is fantastic. I don't see any further questions. If anyone else has not posting a question, I'm going to assume that that's it. We're doing really well on time. Jeff, thank you so much. Really, always, I love listening to you
George.
talk. Oh, sorry. Yes. Did I miss somebody? Wilson.
Yeah, there's some questions in the Q&A.
Oh, did I miss
There's some questions in the Q&A.
Sorry, dude,
Yes.
I thought I just covered them.
At the
Is
bottom.
there something I didn't that says thank you for a wonderful talk? The last one.
So Nicholas, I will make sure George has a copy of those papers. South African clinicians. I think George is better placed to answer about the demand. But what we have seen at Corielll Life Sciences is that the answer is absolutely yes. That folks at the hospital systems all around in South Africa are looking for ways to implement this, and that's why George and I have been working together. Would they need to be informed and educated? Absolutely, that's always going to help. Right? The more people that have a good understanding of the science and the clinical impact of this, definitely. I don't know if there's other questions here. I know I've only got 1 minute left. So if there are others that we didn't answer, please get those to George. He'll forward those on to me that he can answer, and I look forward to helping you.
Yeah, we absolutely will. Jeff, thank you so much. I just want to thank everyone who's helped us, our friends at Institute of Integrated Medicine and SADC, Victoria, Wilson, and Mario. You guys have helped us navigate our way through a difficult first webinar. And Jeff, really thank you so much. It's been fantastic listening to you. And thank everyone for attending. And we will make this available. I will send an email out. It will also go on the JDJ website, which is jdjd.co.za. And I thank you very much for attending, and I thank you for your attention. And Jeff, thank you. Have a lovely day.
Thank you. You too. Take care, everybody.
Thank you very much. Right. Bye-bye. Jeff, thank you so much.
Absolutely.
This is fun. Leaving. Yeah, it is fun actually. It's always nice, and I think it's great to keep ourselves abreast of this, the impact. I think what people have not noticed until now is that with your studies coming out and the studies coming after those, the actual impact that pharmacogenomic testing can do in real life situations, not in theoretically I can find X number of variants.
Yeah.
It's when you look at real patients, and so I think I have your paper on the benefits. That's from the teachers' retirement study.
Correct.
I think I have that paper, so I can distribute a link when I send around the link for the YouTube. I'll send a link to that as well.
And I see some folks still here. And one of the questions that I didn't get to answer, I don't know if Miguel Mouton is still on the line, but let's make sure. The question asked was how drug-drug interactions play a role in pharmacogenomic tests. And just briefly, I don't actually see the name still here. So that person's not here. But for everybody else who's on the line, who's thinking about it, there's something called phenoconversion. Sorry. So drug-drug interactions through those metabolic pathways can actually turn somebody from a normal metabolizer into a poor metabolizer. And so we want to have that information as well. So if you've got a green light that says this drug is okay for genetics, but you haven't looked at the drug-drug interaction, you're actually not getting all of that information. So for those folks on the call, you guys got a little bit of an extra bit there.
Yeah, that's very cool. Yeah, I don't know if there's something wrong with my chat, but I only had the 2 questions that I read on my chat.
There's actually 2 places that chats can show up in these. One is a button called Q&A there.
Oh, that's probably why I'm in the wrong place.
We've got this talk, are there
Q&A.
demand,
Yeah, there it is.
estimated cost. I'll let you hit the cost. Do you have to do the whole panel? Karen, are you still on? I don't see
Sorry,
Karen
Jeff?
on names. Yeah,
Yes.
Yes, so I recorded all the questions, so I'll send
Great.
them to
Awesome.
you. Fine?
Thank you so
Fantastic.
much, man.
Okay.
Yeah,
see.
I think some
Yeah.
of these can be answered by George specifically. But big pharmaceutical development in support in Africa. Yeah, great comments in here. Great audience.
Yeah.
Much apprecited. George, as always, fantastic.
Yeah.
Good seeing
Jeff,
you.
thank you. Yeah, have a great day.
All right, you too. Take care.
We're going to bail now.
Yeah.
Bye-bye.
All right, bye-bye.